Well, welcome everybody, and thank you for joining us today for our Domestic and Family Violence Lunch and Learn for the Central Coast region. I'm Sandy Vincent from the PHN Education team, and today I'm joined by Dr. Colette Horrigan, who is a Central Coast GP specialising in women's health, as well as most recently providing medical services to women and children's refugees. We're also joined by Anne Wright, who is a Domestic and Family Violence Specialist Worker, and the Central Coast DFV Local LINK. Thank you both for joining us today. Before we begin, I would like to acknowledge the traditional custodians of the land that we work on. For us, that is Dark and Jung land, and pay my respects to elders past, present, and emerging. A few things to let you know about today's session. We are recording this session, so you will be able to view the recording on the PHN Education Library in a couple of days' time. As attendees, your microphones and your cameras are automatically disabled, but we will have questions at the end, so please do use the questions box. You'll find it in your tab. If you just drop it down, you can send through those questions and we'll answer those at the end. And an evaluation will come through to you at the end of the presentation. We're very grateful to have your feedback, so please do complete that. All right, I'm now going to hand over to Colette to start the presentation. I'm just going to launch the slides. Colette, just let me know once those pop up.
Yeah, so we're going to be talking about looking at how we manage domestic violence in the primary care setting. So thanks, Sandy.
Is that working?
Yeah, okay, so why we're actually incorporating it into primary care is because when we look at the risk factors for the burden of disease, and we think about things like smoking, obesity, illicit drug use, physical inactivity, childhood sexual abuse, all the workplace hazards, alcohol use, we actually find that surprisingly, domestic family abuse and violence for the 18 to 44-year-old age group is a bigger risk. It actually contributes 5.1% to the burden of disease, which is an enormous amount. And unfortunately for our Indigenous patients, it actually is 6.3 times higher than for non-Indigenous. So it actually costs the health budget an enormous amount of money, because in the past, it was really only the police and specialist services that were involved. And by then it gets to the pointy end. We want early intervention, which is why we want primary care, general practices, practice nurses and GPs to be involved in doing this work. So now we're just going to have a look at the next slide. So there's another reason why we want primary care to be involved. Because when we're looking at current partner violence, the first group these women will go to for support is actually a friend or family member, which is understandable. But then the second most sought after support is from the general practice, from their GP and practice nurse. And this is often because they have a rapport. They know that the GP and practice nurse are bound by confidentiality. They trust that they will be given good advice. So the victims actually want us to be doing this work. We're not interfering with their lives, we're actually helping them. Now, when we look at past violence, the police are the next source of support they'll go to. So 5 victims a week may be unseen in your general practice. And that figure comes from the number of victims that a full-time GP would see in a week. But as we know, we're not identifying them. So what we want to do is we want to make domestic family violence and abuse visible. We want to think of it as one of those important risk factors. We know that we ask new patients about smoking, their alcohol use. We feel comfortable asking those things, but most practice GPs and nurses don't feel comfortable about asking domestic violence for many reasons, but I can reassure you, you will never offend the patient by asking them, how are things at home? You know, they'll actually think that you're actually quite holistic and thinking about them as a whole person rather than just that sore throat or sore toe that they've come in presenting with. The victims often feel very ashamed, which is why they don't come in and say, oh, I'm experiencing domestic family abuse and violence. They feel ashamed, they feel frightened, they don't know whether they're going to be judged by you. So this is why they often don't declare it when they come to you. We have to be very good at picking up the clues and actually asking the right questions. Thanks, Sandy. So we're going to be looking at the primary care response. So that is spotting the signs, picking up on the clues, like that woman who's hypervigilant, who isn't sleeping, who has chronic headaches. She can't concentrate, she's worrying all the time. Or that child who's withdrawn or bedwetting or might be acting out. We have to feel confident starting the conversation, asking them how are things at home, but most importantly, linking them for support. Now, in general practice, there's a lot expected from you, and we certainly don't expect you to turn into a domestic family abuse and violence specialist. We already have our wonderful specialists like Anne, who will be talking to you in a minute. And so our role is to identify support and to link them with the services. You know, there's a lot of work that goes on once a patient is linked with these support services that Anne will discuss. But we don't have the capacity, we don't have the time to do this, and we certainly don't want you to feel like that's your responsibility. You know, you don't need to be ringing up refuges and you don't need to be ringing up counsellors and things. You know, basically Anne's team will do that all for you. And it's wonderful. There's just one referral place that you need to know about. So it's really important that linking for support is the most important thing that I want you to take away from this webinar. Now, we're just going to have a look at how we start that conversation. So there are 4 steps in starting the conversation. So the first one is asking the question, how are things at home? As I say, no one's going to be offended by you asking that. Is there anything else happening which might be affecting your health? Which is a good one to ask that patient who's hypervigilant and not sleeping and just chronic headaches. You know, ask her, you know, whether she can identify some stress that might be causing that. And then funnel those questions. You know, when they disclose, yes, well, my partner gets a bit angry at times. Explore that. What happens when your partner gets angry? And also you can use statements such as, sometimes partners use physical force. Is this happening to you? And sometimes the patients won't sort of identify that it is domestic violence. You know, sometimes I've had women say to me, oh, no, he's you know, he'd never hurt me. He's pushed me up against a wall, or he shoved me on the floor. And they're not identifying that that's actually abusive behaviour. So sometimes having that conversation can help them identify that that actually is abusive behaviour. Now, listening without judgment is really important because the victims do fear that they're going to be judged by you, and they don't want to damage the bond, the rapport that they have with you. So statements such as, I hear you and I believe you, are important. I care and I'm here for you. You know, knowing that you're going to be supporting them and you'll support them even once you've linked them with domestic violence specialist services, the local coordination point. You know, when they come back to see you, you know, you're still offering them support. So validate their feelings. Now, something I commonly say to my patients is, I'm sorry this has happened to you. Now, often the perpetrator will say to them, you did something that made me angry, so that's why I hit you, or that's why I did that to you. So sometimes they come in feeling that they're to blame, that it's their fault. it's really important that you tell them this is not your fault. You know, you're not to blame for this. It's the perpetrator choosing to use abuse that's to blame. And often thank them for, you know, just being so open and honest, because it really is a big thing for them to divulge this to you. Now, encouraging action. This is really important. So now that you've identified that there is domestic family abuse and violence occurring, it's really important then that you get them linked with the support that they need. So once we identify what's going on in that relationship, we want to refer them on. We get the patient's consent to do that. If that patient or their children, anyone else living in that household, are at imminent risk of harm, we do not need the patient's consent. Under the Criminal Law Act, there's Section 13A, Section 16A, we can actually contact services if we feel that patient needs to be saved and looked after and they're not identifying that. Now, before we send them though, before they leave your room, we just do a really quick safety check. And things like, do you mind if I ask you some more questions about risk to help keep you safe? And before you leave, I'll just, like to put together a really quick safety plan for you, just in case things escalate from the time you leave here to the time you see the services. Now, the services, the local coordination point ANZ team, they will make contact with the patient within 24 hours. So it really is rapid. But if there's something that you're not happy with, that you think something could escalate later that day, then it's really important that you actually keep that patient safe. You can also, let the team know. You can actually let them know that you're quite worried. They will contact them sooner. You can ring Anne even. I've done that in the past. I've rung Anne and she's responded virtually immediately to it. Now, so as I said, consent is really important, and sometimes patients will balk at that, thinking, oh, it's not that bad. But I sort of let them know what that service involves, and it's there to support them. They worry that their partner will find out. So what we do is, on the action plan, the first page is patient, details: name, address, age, contact number, best day to contact them, best time to contact them, and whether it's better by phone or email or even via a friend's phone. It may be that it's safer to bring that patient back in to the surgery for an appointment and make it so that Anne's team can speak to them while they're in the surgery, if there's no other safe way that they can be contacted without the perpetrator being present. It's important to identify also if they're pregnant, and also the names and ages of the children living in that household as well. The details of the perpetrator, and if the perpetrator is in the household. So putting down his address as well is really important. Now, on the second page, there's a list of safety questions. The first three indicate very high risk, and the others indicate definite risk, but it probably doesn't need to be acted upon like that day as an emergency. Now, the third page, on the bottom of the third page, it actually has a place where the patient can sign, and that's then their consent. It's important to get their signature when you send it through if it's a non-urgent referral. And by non-urgent, I mean that, they're not at imminent risk at that moment. But certainly we want to get these referrals through as soon as possible, because we know how the situation can change quite rapidly. Now, the patient plan is basically things that you're identifying that are an issue, the goals, what the patient would like out of it. Because sometimes we know what we would like to do, but it's very important we work with the patient at their pace and identify what their main needs are in the beginning. And then we can also put down what the needs of the children might be. They might need speech therapy if they're delayed, occupational therapy, psychology. So we can put together a plan, and that doesn't all have to be done in the one session. The plan for the future, just keep them safe, and then the plan can be built on later, what services they're going to require. So now we're going to just look at what our local link. So we call Anne our local link. So she's our conduit between general practice and the local coordination point. So I'll just hand over to Anne. Thanks, Anne.
Thanks, Colette. So just a little bit about the service, where I'm from the Central Coast Women's Domestic Violence Court Advocacy Service, and we're a statewide service. We have 27 DV CAS is what we are called, 27 DV CAS across the state, and most of our work is from police referrals, and we work with female victims of domestic and family violence from the ages of 16. So most of the work does come from police. So whenever there's any domestic violence that's been reported to them, or whenever the police are called out to a DV incident, they make a referral and it goes into a database, and then it comes through to our service. And we work closely with the domestic violence liaison police officers across Tuggerah Lakes Local Area Command and Brisbane Water Local Area Command. So once we receive that referral, we also receive referrals from external services as well, and the approach to deal with all referrals is streamlined, and it's the same, doesn't matter where it comes from, it's the same system. So we will make 3 contact attempts to contact the woman at risk across a 5-day period. Once contact is made, we'll do a safety assessment, we'll talk about possible referrals and discuss what services that might be able to help and support them. And then depending on their needs and their circumstances, we can refer for counselling, legal advice, parenting support, crisis accommodation. We can offer services that provide security upgrades, security cameras, whatever it may be. We'll go through all of that with the woman that we're talking to. We also have our focus workers who work specifically with Indigenous women, older women, women who identify as LGBTQI+, and youth. We have a youth focus worker as well. We also support women going through the court process. So if they're ABOs or criminal charges and they're going through the local courts, we're co-located at Wyong, Gosford and Woy Woy local courts, so we will support women through that process as well. We have a safe room at the court. We have a room where women can give evidence via an AVL suite so that they don't have to go into the courtroom, and yeah, we'll support them through that whole process as well. As far as referrals, we can accept referrals via medical objects if the practice has medical objects. Otherwise, email, fax, or just via the phone. And we're available Monday to Friday between 9 and 5. And as Colette said, we're more than happy just to accept a phone call. Time's always an issue, so it's fine just to pick up the phone and say, look, we've got this lady, here's her name, number, she's given consent, and we're more than happy to give her a call and go through that referral process. I think that's about all, Colette, unless there's anything else I can add.
No, that's fantastic. So today's webinar is just a little taste. There is 2 1-hour training sessions. The first session is foundations for your entire practice, including reception staff. And then the second session goes into more clinical aspects, and that's for your nurses and doctors. So I do encourage you to do the full training, and that will give you even more confidence in managing these patients. But we might just see if there's any questions.
Hi there, thank you so much. Thank you for that. That was excellent. I am just pulling up the questions box. I don't actually see any questions at the moment, so please do feel free to send through any questions that you have. You'll find a little questions tab in the panel, and you just drop it down and then you can type in your questions and send them through to us. Here we go. Is it available for men? Is a question from Alison.
No, unfortunately, it's a women's service. Now, the men don't miss out. They just have to go through a different referral pathway. So the men can go through the men's referral service, the men's line. So we think about the men in terms of the male victims, which can go through those pathways, and also if it's the perpetrators, because there are courses for the perpetrators, there's help for the perpetrators. They can also contact the men's line to get more information about this. And there's two men's behaviour change programs that are run out of Tuggerah, one through Catholic Care, one through Baptist Care. So the good thing is that sometimes when a perpetrator decides, yes, they want help, they're really not coping, they really don't want to be doing this, they can see that they're destroying their family, then the men's line can actually provide counselling until they actually enter the program. So they do get well supported. There's also the domestic violence line as well. So basically, Anne's service is, Monday to Friday, and is it 9 to 4:30, Anne?
It is, yeah, 9 to 5.
So out of those hours, the DV line is also really, really good as well. And what they do is they do the same work as what Anne's team would do, and then they will feed back into Anne's team as well. So, you don't have to think, oh, drat, it's 1 minute past 5. I can't get a hold of the local coordination point, otherwise known as, WDV CAS. You can just get hold of the DV line and they will give you good advice. Now, think of Anne's team also there to support you, so that if you just don't know what to do, if it's one of those cases and you think, look, I really don't know who the victim, I really don't know who the perpetrator is, I don't know what to do about this, it's all such a complex mess, then you can contact Anne, and Anne will actually help sort it out. She can make an appointment to see or talk over the phone with the female in the relationship and work out what's actually happening. Because once again, in general practice, you don't have the capacity. Not all patients are good historians, and sometimes the facts get very, very confused. And so this is where it's good just to refer that on as well. So Anne, I'll give you just a little case history where Anne, I changed practices, and my practice hadn't actually downloaded the template yet, and I really wanted this referral to go through. So I rang Anne and got a very quick response. And so what happened was that Anne had contacted the patient within 24 hours. She had to flee and leave her husband and her 2 daughters behind. She left and went and stayed with a friend for safety. She had no money. The husband, he had cut off her credit card, he'd cut off everything. So she literally left with nothing. And she was in crisis. And so Anne put together everything very quickly for her. The other great thing about Anne's team is they will help the patient to access victim services counselling. Now, from experience, it takes me about 20 minutes to work through a referral with a client to access that for them. It's better than the mental health care plan that only gives them 10 sessions a year. And if they go through Coast and Country Primary, they can get 12, but this gives them 22. And the therapists that work with victim services clients are all trauma informed. So it really is a fantastic service. The approval usually comes fairly quickly, and most of my clients can start their counselling within a few weeks of the referral being made, which is also quicker than undergoing that process of the mental health care plan. So it's free of charge. Whereas, as you know, if you send someone under a mental health care plan, there is actually going to be a gap payment. And sometimes that gap payment is $100, and these women just cannot afford it. The other thing I want to mention with counselling too is that it's not appropriate to send them to couples counselling. and it's not appropriate to use anger management counselling, because this just isn't about the perpetrator just getting angry. This is actually darker than that. He's actually choosing to control his partner. And that's more than just angry. It's not just he's losing it every now and again. This is cold and calculating when it comes to coercive control. It's all planned. So those forms of counselling aren't appropriate, because I know many women experiencing domestic violence have been referred off by their GP to couples counselling, and it just gives their partner more control. And it's actually not safe for them to be in that situation. So this is where, you know, Anne's team's wonderful, because they will link them. Now, it doesn't matter, as Anne was saying, you know, whether they're Indigenous, non-Indigenous, if culturally diverse, you don't have to worry. They deal with everything. You know, they've got appropriate workers so that they can handle any situation. So you don't have to think, oh, look, they're disabled, so I have to go through disabled services. Everything just gets channeled through to the local coordination point. It really is a wonderful service. And the thing about it is that as primary care providers, if we don't use this service, we may lose access to it, because it's so fantastic that we've been provided with a local link, and Anne is ours. Each region has a local link that you've got a face and a name, and you can just contact her and she will feed back to you. She'll follow up for you. It's as one GP said to me, it's a shame we don't have a local link for everything, for respiratory care, diabetes and everything, because it really does make our job a lot easier. So all we need to do is really identify, do the safety check, support them and get them as swiftly as we can through to Anne's team. And there's nothing more rewarding than helping a victim of domestic violence, because I've sort of seen many women through on their journey, and their health and their outcomes improve so much. It's like when we were looking at that slide for the burden of disease, they by just supporting them and getting them the help that they need. We don't tell them as GPs to leave the situation. We don't put unrealistic expectations on them. We hand them over, because that is a journey and it's a process. And if we just go, well, why don't you just leave? It actually increases the risk to them, because we know that most women get murdered within the first 3 months of leaving their partners. So it actually has to be handled by specialists. They need to be guided. Safety needs to be put in place. It's paramount. And as GPs, we're really not able to do all that. We can do some of it, but this is where it's important that we hand over to our local coordination point to ensure the best outcomes for our patients. And believe me, they'll be forever grateful that you've assisted them and supported them. So have any more questions come through at all, Sandy?
No more questions, Colette. That's all, just the one question. But we are at almost at time.
Okay.
Got 2 minutes.
Okay. I was just going to ask Anne, if you could just let them know what they can expect in terms of information back from you.
Yeah, so I will always send a follow-up email and to just let the GP know that I've made contact with the woman, or if I have not been able to make contact, and just what services and referrals that I've made, just so that they are kept in the loop.
And that's wonderful, because we know that in the past, GPs have referred out to a lot of services and their patient disappears into the ether, and they don't know what's gone on, and they feel a bit silly when the patient comes back and they have to actually quiz the patient to find out what happened. So this is really wonderful, because what Anne does is she closes the loop, so you're referring to her and she's feeding back to you. And I must admit, from feedback from specialist services, I've actually learned a lot. It's actually helped with my education, knowing the process and actually how these services can link with so many community services I've never even heard of. And so, you know, as GPs, there's no way we're going to keep up to date with what's available. But Anne's team, that's their job. So, you know, once you've handed your patient over, you know that they're going to be very well looked after and they're going to be monitored. And then to me, that's a huge relief, because as GPs, we worry about identifying problems, but then it becomes like a hot potato. We don't know what to do with it and we worry about it. So this way, you're not left with a hot potato. All you need to do is identify it, support it, do that safety check, safety planning, and then Anne's team will do the rest for you. So it really is a wonderful undiscovered service. So I'm so happy I can, you know, share this information with you, because, you know, it's just going to be wonderful support for your practices.
Fantastic. Colette and Anne, thank you so much for spending time with us today, but mostly thank you for the amazing work that you're doing in the community. Very much appreciated.
Thanks,
And
Sandy.
with that, I would like to say that's the end of our presentation today. Please do complete the evaluation. And if you do have any questions after this, just reach out to the education email and we can pass those on to Colette or Anne. But thank you very much, and you can watch the recording or share this on the Education Library in a couple of days' time. Have a great rest of your day, everybody. Thank you so much.
Thanks, Sandy. Thanks, Anne.
Thank you.